Hello everyone, welcome to this virtual AMR Innovation Mission UK 2021. My name is Peter Durkin. I work for Innovate UK, which is the UK's innovation agency, and I run its global missions program. I am your chair for today, and I'm absolutely delighted to welcome so many of you to this event. Innovation for over 350 people global mission registered from over 60 countries. And I do encourage you to continue to reach out and connect to like-minded AMR professionals around the world using the Beta Match platform. This platform is now open, and it will remain open for another month after this event. So I sincerely hope we will inspire and inform you so that together we can solve the problem of antimicrobial resistance. The theme for today is microbial diagnostics, and I'm very pleased that we have such a brilliant list and group of speakers for you today, and I welcome them warmly. A couple of bits of housekeeping. All the slides will be made available online. We have a Q&A session at 2:45 to 3 o'clock, so I'm encouraging you to register for that as well. If there is time in the sessions for questions and answers, then we do that as well. The sessions will be recorded, and today's Twitter handle is @AMR Mission UK. So, first of all, I welcome Dr. Ruth McKernan, who is the chair of the UK Bioindustry Association. Ruth has a very distinguished and successful career in the neurosciences and pharmaceutical industry and in innovation. She held senior roles in Merck and Pfizer in the UK and the US. I had the pleasure actually working in Ruth's team at Innovate UK when she was our CEO between 2015 and 2018. More recent endeavors include roles at the Dementia Discovery Fund, an area I know is close to her heart, as well as being founding director at Diagnostics, a startup funded by that fund, and which is focused on treatments for that disease. In 2013, she was appointed CBE for Services to Business and Innovation. Ruth, a very warm welcome, and over to you.
Thank you very much, Peter. And welcome to the 350 delegates out there in Zoom land. I mean, it's an absolute pleasure to speak to you and to see so many people interested in AMR, which is, going to be a major issue for the globe. I understand that 25% of people joining today are from the UK and 70% from other parts of the world, which is fantastic. And I also understand that there are over 150 scheduled matchmaking meetings. So if you haven't met your match, please do sign up. This is a wonderful opportunity to push forward what we need to do in AMR. I understand that 50% of our attendees are academics and 50% from industry. I would say that's the perfect combination. So if you could move on to my next slide, please, Peter. So what do we know? We know a lot now about antimicrobial resistance, and I think the time is right to really try and move on from where we are today. We already know about the inappropriate use of antibiotics, not just in healthcare, but also in agriculture, and this has been going on for decades. And we already know that AMR causes more than 700,000 deaths per year, and it's set to become much worse. The latest figures were we expect deaths to be maybe 10 million by 2050 and costing 66 trillion in economic loss. And it could be the leading cause of mortality globally, overtaking cancer, with significant direct economic burden on the health system, not just directly to our health services, but also indirect costs due to lost productivity, long-term health impact, impact on carers, etc. I'm just getting a note that if you're not on mute, could you go on mute? Because that's so much better. Thank you very much. Whoever the person out of 350 was, it's worked. Next slide, please. Next slide, please, Peter. As we're waiting for the slide to move on, let me just talk about some of the important issues we've had and what we've learned from COVID. I'm just checking, can you hear me?
Hi, Ruth, I can hear you.
Okay. Can you move the screen on, please?
I have moved it on.
Okay. Well, it's not moved on mine, but I will continue on. So what have we learned from COVID? The first thing we've learned is that health security is now a priority across the world. It has really been a wake-up call, I think, to realise how fragile our health security systems can be. And one of the factors that is really important is the number of people in hospital and the duration of their stay. That's critical. And what we've seen is that in terms of the economy, in terms of maintaining the integrity of any country, the number of people in hospital and the duration of their stay matters a lot. And that will be the same with AMR, because people will need to stay longer in hospital. They will need to stay longer in ICU. And we've started to think about how to manage those issues. The pandemic has highlighted concerns about AMR, but one positive aspect of that is I believe that resistance is now much better understood. We watch to see what resistance mutants are arriving around the world for COVID. I live in Kent. There is a mutation in COVID-19 that everybody knows as the Kent variant. We can expect the same with AMR. We will need to understand where resistance is arising and how to treat it. In fact, AMR is a slow pandemic and it has huge implications for public and global health. We have been emerging resistance over decades. There's also a direct learning from COVID, which is that because people are spending more time in hospital, because they have additional surgeries, more time in ICU, additional infections, there is an increased need for the use of antibiotics as a consequence of COVID. So that is only going to make our challenge more difficult. Now, for COVID-19, there have been three elements to the solution. Firstly, prevention. Secondly, diagnosis. And thirdly, new therapeutics. And it will not surprise you that we will have exactly the same elements to solving our challenges in AMR. So next slide, please, Peter. So how are we going to approach the problem? Again, prevention is important. The good news, I think, here is that our learnings from COVID have shown that people are willing to change their behaviour. They're willing to give more space. They're willing to wear masks. They're willing to wash their hands more frequently, and they're willing to listen to public health guidance. And I know we're going to have some conversations around that over the next 2 days. The second area, which is also incredibly important, is diagnosis. And diagnosis is not just one thing. Obviously, we need to test for the presence or absence of a bacterial infection. And just knowing whether it's a virus or a bacterial infection can dramatically cut overuse. Then secondly, we have to be able to match the pathogen to the optimal existing treatment. Thereafter, we still need to have surveillance of drug resistance and put a large amount of effort into gathering data and global monitoring. We now understand the size and the challenge of how to maintain healthcare security in the face of COVID and increasingly in the face of antimicrobial resistance. And the last approach to the problem is obviously new therapeutics. And it's fantastic to hear that we have so many people on the call today who are either from SMEs or from large companies who are interested in developing new therapeutics. And I think this is going to be a very important part of our work. My 20 years experience in pharma led me to believe that it takes a good 10 years to develop a new drug. No longer is that true. With the emerging efforts in having better licensing procedures, rolling review of documents. We are able to develop new therapeutics and vaccines, of course, much more quickly than we used to. But now is not too soon. We are going to need to have many new therapeutics for treating antimicrobial resistance. At the moment, there's a lot of work ongoing to look at new therapeutics for coronavirus, and there will be combinations that are required. I can well understand that we will need combinations of very safe new therapeutics to treat AMR. On to the next slide, please. So just to give you a little bit of background into the AMR therapeutic landscape, if this isn't your area of expertise, my friend and colleague Deborah O'Neill, who's the CEO of Novacta and is the BIA's industry representative on BEAM, she has shared this slide with me. So she represents us on the biotech companies from Europe innovating in AMR research. And this is how she laid out the challenge, and I can fully agree with her. Innovation in AMR has been stalled, and the business model, many have described as broken, and it has made investment really difficult to achieve. And that's because one can only hope and expect that the volume of sales will be low. In fact, the lesser use of new antimicrobial drugs would be a sign of success, because it means that actually people are behaving well, minimizing the use of existing antibiotics and therefore reducing the need for new ones. But we must have new products. We must have them and keep them in reserve to limit the rise of new resistance. As a consequence of this, pricing is low. And that means that it's really expensive to develop new drugs compared with the old and existing generic drugs. So R&D costs are inevitably higher, and the return on investment is going to be hard to achieve. We have to think differently about how we create new therapeutic products. And there are many companies working in this area. And I think one of the outcomes of COVID will be to highlight that we need to be continually inventing new therapeutics. And there are many SMEs in this area. So there are currently about 480 antibacterial programs in development. Most of those at the moment are owned and being carried out by SMEs. But academia is a strong player here. And what I see is that actually Big Pharma is moving back into this area. And of course, we always have support and input from non-profits and public-private partnerships. And in showing this slide, what I'm trying to demonstrate is that there is a whole ecosystem of European SMEs who are focusing on AMR, and they are working in partnership with Big Pharma and with research. In fact, one of the things that COVID-19 has really shown us is that the only way to achieve at speed is to work in partnership together. So as they say, if you want to go fast, go alone. If you want to go far, go together. In this, we need to go fast and we need to go far. I was talking to a colleague who's been working on COVID-19 and the production of the vaccine, and there are 50 elements, 50 parts to making a vaccine, and they come from all over the world. The solution to this has to be global. So the last slide, please. What can we expect of the future, and what are we looking for as an outcome of this meeting over the next couple of days? We are really looking to build innovation and partnership, to build those relationships on many different levels, between industry and academia, between industry and government policymakers, between researchers, between SMEs, across the whole ecosystem, because that is the only way that we can be successful in combating antimicrobial resistance. And the people on this call, the people who are joining this program, we're relying on you to make this work. Thank you very much.
Thank you, Ruth, for such a fantastic welcome and fantastic introduction to this important topic. We do not have time for questions and answers, but we have a specific session between 2:45 and 3 where we will pick up any questions you might have on this session. So next, I welcome Professor Till Bachman of the Edinburgh Medical School at the University of Edinburgh. He's a world expert in the field of antibiotic diagnostics. He's a coordinator of a number of international projects and programs in this field, an editor of the journal JAC Antimicrobial Resistance, and he holds a range of global, industrial, and institutional advisory roles. Till, a very warm welcome, and over to you.
Thank you very much, Peter. Yes, here's the first slide. And thank you very much for the invitation, the opportunity to speak. And thank you, Ruth. I couldn't have a better introduction, especially at the end. Collaboration is needed, and we have to have a global view. From that perspective, I changed very, very slightly the title Martin gave me about the impact of microbial diagnostics on the curbing of AMR in a personal UK perspective. So I take my personal view from the UK out into the world, and I hope over the next 30 minutes I will give you the good background and a data-rich presentation about what we can do with microbial diagnostics. Peter, if you could go for the next slide, please. Thank you. So just to get us all up to speed, I'm very sure you all are very well aware of this, but to set the scene, with clinical microbiology, we have an unmet need that as soon as a patient comes to see a prescriber or a doctor with a disease which is diagnosed, and we suspect the need for an antibiotic therapy starts immediately. But we take a sample usually, and we cultivate bacteria to identify the pathogen. After we have done that, roughly we then detect the susceptibility or the antibiotic resistance again by culture. So that is the standard procedure at present, and there is an obvious issue with that at the time when the therapy started, we don't know exactly which pathogen is treated and what is the susceptibility. So if you click next, please. So what we really would like to have is rapid diagnostics, which tell us at the start of the therapy or help with the decision-making of the therapy to choose, for example, the antibiotic, to choose about patient management if you want to isolate a patient, for example. We generate surveillance data, which can then in turn be again used to choose the right antibiotic therapy. And quite specifically, rapid diagnostics is generally understood to facilitate the development and use of narrow spectrum antibiotics. So strong unmet clinical need and a clear perspective. Next, please. Just again to set the scene, you're all for sure aware of the O'Neill review, which was, if you click next, which presented in 2016, started 2014, the 10 commandments really, how to tackle antimicrobial resistance. And that time we were really all happy about our rapid diagnostics featuring very highly in there. Jim O'Neill also made a very demanding statement there that he was asking for the governments of the richest countries to achieve by 2020 that all antibiotic prescriptions should be informed by an up-to-date surveillance information or rapid diagnostic test. When that was made, 2020 was just around the corner, and everyone was getting quite nervous because of the lack of the suitable diagnostics and implementation pathways, which was generally understood to be the case. If you click next, please. In 2019, then through the work also of the which we did in the UK AMR Diagnostics Collaborative, we published, or it was published, the UK 5-year National Action Plan and the 20-year Vision for Antimicrobial Resistance. In there, a lot of support for the development and the implementation of rapid diagnostic tests, but overall it was a backtracking from the initial demand, which we see on the left, to a guide on the antibiotic prescriptions. to knowing how many of the prescriptions have been actually used or done by the informed by a diagnostic test. And that should be done by 2024, again, just around the corner. If you click again next. So in 2019, the Chatham House and Wellcome Trust involved had a report and a look at the progress and with regards to the report of the AMR review, it was generally considered that there was very little progress made with the development of these diagnostics and implementation. If you click next, in 2020, the situation has essentially stayed the same. Again, a Wellcome Trust report, very important, interesting report, but also here stated, however, there is insufficient development of new products due to market failures and various barriers to uptake. Now, we all understand that developing AMR diagnostics is a very challenging task. Implementing them is even harder. So I think these reports and recommendations clearly highlight that. So all a situation which we are facing. Next, please. As I said, I changed this title slightly with the UK personal perspective, but also I thought it was interesting, and I thought that what was interesting to pick up is that the title actually said about impact of microbial diagnostics on the curbing of AMR. So I asked myself, what does it actually mean? Because how much do we know and what's the evidence for impact which we already make or can make with microbial diagnostics? So I'm going to talk about this a bit more, and about curbing of AMR. What does curbing of AMR actually mean? And these are potentially best represented here by the three blue boxes. It's the impact of the AMR, the spread of the AMR, and the development of AMR. Initially, by diagnostics, really, it's the impact of AMR, what we want to do, because we want to avoid the orange box that we want to avoid that the chosen antibiotic does not work on the patient which we want to treat, or it's the outcome is the desired one. So here we would go with new interventions to do that. Also, what we obviously want to avoid is that we have a development of AMR. And again, here, diagnostics is generally understood that we can prevent that by choosing an appropriate treatment, an appropriate choice of an antibiotic by using a diagnostics. Now, to do that, change of behavior is probably the biggest intervention that we need. Further on the spread of AMR, here, I think the most adverse, or in summary, the most adverse impact is the organism of interest is exposed to AMR. I chose that word by purpose. The organism may be human, but it may also be an animal, or even a plant, which we don't want to expose to AMR because of the unintended consequences by that. Now, this is a very, let's say, top-level look at the framework. If you go to the next slide, I picked an activity, and this is very busy. I apologize for that, but you have a link there. You can visit the report in detail. This is a report from 2014-15, commissioned at that time through a series of workshops by the Department of Health, which looked at the AMR systems map. And I picked two situations here, the hospital, and the next slide is then the GP. Stay on this slide. Sorry, stay on, or if you go back, sorry. Yep, one too much. Okay, thank you. So here, if you look at the reservoirs, these are the pink circles. So in the center, you have the patients, and they sit in a framework of animals, environment, GP care in the community, and international action. So these are this is the frame. And in the center, then you see these boxes. The brown and yellowish box are interventions and so influences of, these are risk factors to develop infection and AMR. And then you see interventions and intended effects. And what you then see, what I added, are these stars, the diagnostics. And roughly, you see that there are a lot of areas where I decided, in looking at this, but if you look closer, it becomes obvious that, or it's even written diagnostics, that diagnostics can make an impact, or it can be chosen to make an intervention at the spread, at the development of AMR, if you take this AMR systems map. So for this presentation, I think the take-home message is that it's important, if you think about your diagnostics, where in these networks, where in the system of AMR are you positioned, and where could you make a difference? Now, this is different to the clinical care pathway where your diagnostic would sit, but it may be similar. So here it's the AMR systems map of transmission. If you go to the next slide, it's similar situation, but here GP care and the community. And what I found striking by positioning the diagnostics stars here is this situation, but here the revealing of the many stars striking by where positioning the diagnostics stars on the top left corner. It's interesting to see that we have the impact of the environment. So we have discharge of antibiotics, we have use of antibiotics and exposure to patients or to members of the community, which then fire back by that potential transmission. So this, if you go to the next slide, so this was the consideration of the AMR systems map. If you move on to the looking what the evidence there is, this is a publication looking at presentations, at studies looking at transmission pathways, drivers of AMR with regards to the different sectors, human, animal, and environment, and how many studies there are. And really two main take-home messages here. Top left corner, you see antibiotic use is a very large bubble. That means we have a very good understanding that prior antibiotic use is a risk factor and a driver for AMR. If you go to the bottom left corner, community level factors, it's much lower. So that means it's quite interesting to look at this situation and the potential for getting more information about using these studies to proceed or conducting studies to proceed with generating evidence. If you go to the next slide, please. So this is just an overview of showing molecular diagnostic tests which are already out there, potentially in use or on the horizon. So there's a zoo of technologies out there. And so the question which I want to prepare with that is, why are we talking about developing new diagnostics? If you go to the next one. So here, what this shows us is that the work which we have been conducting in the context of with the WHO, looking at the landscape of available antimicrobial resistance diagnostics and to the investigation of the gaps. So there are two reports. One is the report on the meeting on or a landscape report, and the other one is a meeting report depicting how we came to the conclusion, which is shown on the top left. So here, what we see, there are two levels, level 1 and level 2 healthcare. One is primary care setting, and the other one is the district hospital. And then in the columns, you have the different disease indications, and then in the rows, you have the different types of tests. Now, in essence, you need to look at the colors. Green is what is available, yellow is not fully available or ideal, and red is what is not available. So you could imagine that if you want to develop a diagnostic, you should go for the reds because they are not available, but there is a huge demand. Also here, A and B. A is reduce unnecessary antibiotic prescription, and B is the guidance on appropriate treatment. Now, I really recommend you to look at the report if you haven't done so. But what is also important is if you look at the green sections for UTI, it seems everything is done for UTI. We all know we have a challenge with UTI, and I'm convinced that we can still do something about urinary tract infection diagnostics. And I will come to this further on. Next slide, please. In providing guidance for the development of antimicrobial resistance diagnostics, it's important to have the right guidance, and the WHO has provided this through the development of target product profiles. So in essence, what this is a list of characteristics for which a minimal and optimal requirement is specified. So this guides the developers, but also those who want to use diagnostic tests and those who decide which ones to use on which factors, which properties they should have. And if you look at the bottom there, for example, their time to result for the identification genotypic resistance testing, minimal requirement 90 minutes and optimal requirement 60 minutes in this case. But also what you see down there is list price of assay cartridge is $50 and $10. So these are pretty low for these diagnostic tests. Next slide, please.
Bill, you're halfway through your presentation.
I am. Thank you. If you go to, yes, so here the providing further guidance is a list of diagnostics which the WHO recommends. And if you haven't seen that, this is the essential diagnostics list, now just recently published with the 2020 version. So this provides guidance for deciders, for policymakers, and also for procurement, which diagnostics should be available or should be used. But this is a global list, and this is also providing guidance to develop national diagnostics, essential diagnostics list. And if you look at this, so AMR features in the current version, have a look. So in there is identification of bacteria, there's blood culture, but also antimicrobial susceptibility testing. I've spoken with Francis Moussi, who is leading that, and he particularly invited the audience to check the EDL and provide feedback if there is some. So I provide the email address here. Next slide, please. So this is providing information about what is needed. Guidance. Now, if you have technology in development, or you would like to see, or if you would like to put it in context and develop this towards a application, I'm sure you are aware of the longitude prize, which I mentioned before, where I'm in the advisory panel. It has been launched in 2014. It's an 8 million prize for someone who develops a test which is a point-of-care diagnostic test that will conserve antibiotics for future generations. As you see here, there are 54 competitors already across 12 countries, and many of them from the UK, but also from Europe, the US, and India. And interestingly here, we see many of them focus on urinary tract infection tests, bloodstream infection and sepsis, and respiratory tract infection. If you go to the next slide, please, and you have time to 2022. If you want to go for it. Now, what we see here is this is the list of criteria which you need to meet in order to win the longitude prize. Now, if you look closer to that, this looks very much like a target product profile where, for example, the test needs to be rapid. And rapid means in this case, within 30 minutes, there is from sample collection to result. So this is pretty challenging. The next big challenge for the longitude prize is that for the winner of the longitude prize is that it needs to be globally applicable. And that is most likely to be a point of care test. If you look at all the others, other criteria here, and this is as I said, and as you will probably agree, if you're a developer, quite a challenging requirement. If you move to the next slide. So what is happening currently with the longitude prize, we have advanced technologies which are looking at pathogen detection, susceptibility, and resistance tests. There are clinical performance data collected by the teams. They have attracted more investment to move on, and there are collaborative arrangements for marketing and manufacturing. Obviously, and that was interesting, and Ruth has mentioned COVID-19, of course, this is very dominating all of us. Also for the developers here, we saw that COVID-19 was impacting them, but also provide some opportunity. Now, if we move to the next one, I wanted to give the next slide. I wanted to give you an example of collaboration and how we take these ideas forward of developing diagnostic tests. So very briefly, I'm coordinating a UK-India project called DOSA. DOSA stands for Diagnostics for One Health and User-Driven Solutions for AMR. And what we do here is we turn the usual, let's say, the usual in academia progress around. So we don't develop technology and then look for an application. We do it the other way around. We have an application and we have users. And those users tell us how the diagnostic should look like. If we go to the next slide, it shows the areas we are active in human health, in aquaculture for the environment, and dairy farming for the animal area. So this is a One Health project. And in these areas, going to the next slide, we are looking to develop diagnostics. And basically what we do here is we start with field ethnography. And specifically what we do is design ethnography. So we interact with users to understand the needs, the bottlenecks for implementation, the needs, pathways where diagnostics could be used. We then look into baseline, of course. We want to understand what the AMR situation is in that environment. So we understand what the problem is actually with regards to AMR and infection load, etc. And we do diagnostics innovation. And this is done in the three settings: human health, aquaculture, and dairy. Moving to the next slide, please. Here is the example, or here are some examples given, some imagery. So if you look at the top right corner, there you see there is a lot of interaction with users where we speak, where we understand. For example, you look at the shrimp, and top left of the shrimp is a bowl with water, and in there are larvae. These larvae are exposed to pathogens, and if that happens, then, for example, an antibiotic is used. At the end, what you want to make sure is that there is no antibiotic in the shrimp when they're sold, especially if they should be exported to the EU, then or the US, but with the EU is a particular challenge for India. So they should be antibiotic free. To make them antibiotic free, there are various possibilities, and we have developed tests to, for example, monitor the antibiotic load in food products, including shrimp. Top left is showing the interaction of it's me on the picture, but other UK researchers as well, interacting with community healthcare workers. And these community healthcare workers tell us what they would like to have in their daily interactions. And then on the bottom left, you see different versions of tests which we have developed. And on the next slide, I give a specific example where we develop these very simple strip tests to detect the presence of antibiotic residues. They cost less than €1, less than £1, less than 100 rupees, which in relatively little time tell you, with relatively little equipment, tell you about the presence of antibiotic residues. So this gives you guidance, gives the farmer guidance on behavior in order to avoid antibiotics. To the next slide, please. Just a quick, if you go to the next slide.
You've got 8 minutes left. Just so
yes, thank you. So here, this is a technology which we use. It's called electrochemical impedance spectroscopy. And this is one example of our technologies which we use in our lab. In essence, what this does, it is an electrochemical sensor which measures biomarkers which bind to its surface, which has been functionalized with specific probes. It's a platform technology, and in the bottom, these images, you see this is a reader to read out the electrochemical impedance spectroscopy, which is the electrochemical principle behind that. On the next slide, I show you an example how this is used for resistance testing, or in this case, this is bacterial detection. So here we detect unamplified, if you move on, please, next slide. This is unamplified ribosomal RNA detection. So this is identification of bacteria at very low concentration. So no PCR involved, directly point of care compatible, no amplification. If you move to the next slide, we do the same thing for resistance testing. So we have done this by isolating of plasmids. These plasmids are then hybridized to the PNA functionalized electrodes. On the top left, you see that in the flow cell, which is this tiny little image. And then we see the signal increasing, and you see these various results there over time, how or with the concentration, how these signals increase. And this can be done for colistin, for carbapenem resistance, or methicillin resistance. For methicillin resistance, we have detected not plasmids, but genomic DNA. Next slide, please. We have also done this for the direct detection with using polymers to directly hybridizing bacteria. Moving on. So in the remaining time, I wanted to quickly go through slides of the ValueDX project. And this is an IMI, Innovative Medicines Initiative project. Going to the next slide, please, which has 26 partners in this project. Is coordinated by the University of Antwerp, by bioMérieux and the Wellcome Trust. Going to the next slide, please. It addresses the key challenge of identifying the value of diagnostics as opposed to the cost per test. We all speak many times about cost per test and how expensive is your test. In fact, what we want to know is what's the health economic benefit, what's the benefit of using a diagnostic test, for example, in terms of reducing length of stay, better clinical outcome, etc. And for this, we conduct these four main objectives. So I have economic frameworks, a European standardized care network, we have clinical studies, and we identify the psychological, ethical, and social barriers which prevent more widespread adoption of diagnostics. So just as a quick highlight of this ValueDX project, watch the space, there's more to come. Go to the next slide, please. And so we have these, we can skip that, by the way. So if we move on in the interest of time. So just as I said, ValueDX as a key project which is addressing the value of diagnostics. So in the very last minutes, I wanted to show you the outlook for available collaboration opportunities and funding opportunities. And as I am the vice chair of the scientific advisory board for JPI AMR, I have a keen interest to promote this initiative, this funding instrument, which is available globally. And you see here the countries participating. Next slide, please. The JPI-AMR has a strategic research and innovation agenda, and you see here the various topics on the left which are covered by that, including diagnostics. So development and improvement of diagnostics to improve the use of antimicrobials and alternatives to antimicrobials. And you see on the right that there's funding provided for the diagnostics so far, but as you can see, it is not the leading area where the most of the projects and networks have been funded. However, there has been significant funding, and if you move to the next slide, it is, this is showing who is participating globally. So we have a large audience today, and I'm pretty sure some of you will be in these countries. So it is, we have participated in this extensively and have also global partnerships. Even if your country is not directly participating in a call and is not a member of JPAMR, there might be opportunities to and ways to participate in funding and funded projects. Moving to the next one. Next slide. This slide is showing us an overview about the AMR diagnostics, which has been funded through the JPI-AMR. So considerable number of researchers have been funded in the area of the detect AMR and different reservoirs, identifying barriers for the development and implementation, new technologies, and technologies focused on to improve personalized therapies. Moving to the next is giving a bit more. Next slide, please. So this is showing the networks which have been funded, and I was lucky to coordinate two of them, the AMR RDT and AMR DX Global. Here we looked into identifying the barriers of development and implementation of rapid diagnostic tests for AMR, and this was published with the developmental roadmap for AMR susceptibility testing systems. We also looked at AMR DX Global for training requirements because we have identified that as a major barrier for AMR diagnosis. Currently running is SEC for AMR. As you can see, this is a NGS and AMR diagnostics network, and the other one was in veterinary diagnostics. And with that, I think we can move to the next slide. I'm very happy. I want to thank you for your attention. I'm very happy to answer any questions later on in the Q&A session. And in the very last slide, you have my contact details. If you don't reach me today, you can reach this at a later time point. Thank you very much.
Thank you, Till. That was an excellent, very comprehensive overview of very difficult but important topic. Thank you so much for that. Just a reminder to everybody, so these slides will be made available at a later stage. We do have a 2:45 to 3 o'clock session for answers to any questions you have. So please post those in the chat on the platform. The sessions will be recorded. And again, another reminder, the Twitter handle today is @AMR Mission UK. So next, I welcome Mark Miller, who is Executive Vice President and Chief Medical Officer at bioMérieux in France. Mark has a strong scientific and clinical background in infectious diseases, microbiology, and epidemiology. He had a number of senior roles in these areas at McGill University in Montreal, Canada, and he joined bioMérieux in France in 2012. Mark, a very warm welcome to you, and over to you.
Great, thank you very much, and thank you for having invited me. And I do have this role. There's not many of us who've successfully made the bridge between academic medicine and industry. And certainly when I arrived at bioMérieux, it was an eye-opener. And part of what I do is including talks like this, where we try to get closer between researchers and industry, because in general, there's just not enough dialogue. So I'm hoping that with this, we can increase the amount of interaction between academics, researchers, small enterprises, other people who are working on great innovation ideas, and those large industry companies like bioMérieux that can actually deploy these solutions worldwide. I just want to follow up on a couple of things that were already said. Number one is partnerships and collaborations are absolutely key. None of us in this day and age can do anything alone. So I totally agree with that, whether it's financing, whether it's research collaboration, whether it's scientific collaboration. And I totally agree with Till's comment. Why do people keep looking for new companies to invest in and new innovations when there's already so many companies already working on it, and you can hit the ground running by adding financing and support to those companies to get to the marketplace faster? Why do people insist on recreating and reinventing the wheel every time? But that's a pet peeve of mine. So my role today is to tell you the pains and pearls from an industry viewpoint. And I know that the beginning part is going to be depressing because I'm going to tell you all of the obstacles in the roadway between you, any researcher, any innovator, and getting to the marketplace. But I will finish off on a positive note with two very good successes. So if I have the next slide, please. So why would a company be interested in decreasing antibiotic use to combat AMR? When you've got people working on innovations and the scientific community, and they have a choice to go into oncology, into prenatal diagnostics, into something else, why would they go into AMR? And certainly I'm very biased because 85% of what bioMérieux does is involved with AMR, so I'm very biased. But I'm going to try to give you a little brief 5-minute overview about why a company would be interested in AMR diagnostics. Next. So this is very interesting. And when I read this, it really hit me. This is a Wall Street Journal article about AMR, and they went and interviewed a bunch of people. And this is a general doctor in New York, and he said, listen, I can either prescribe $4 of penicillin on the chance that a patient has a strep infection, or I can order a $51 strep test to make certain that he does. And for the patient struggling to make ends meet and doesn't have money, et cetera, I just prefer to give the $4 penicillin. It's easier, it's faster, the patient wants it, I don't have to spend time explaining, and it's done. Why would I use a diagnostic? And this is the type of behavior that we have to fight no matter how good our diagnostics are. The biggest obstacles, which I'll show you in diagnostics for AMR, are number one, reimbursement, because if there's no reimbursement, nobody uses it. And number two is behavior. And I know this has nothing to do with science, but that's it. Reimbursement and behavior, despite that they're not scientific, are the two biggest obstacles in getting AMR diagnostics into the marketplace. Next, please. So I love Till's slide because it's much more complete than mine, and it includes everybody in every stage. But essentially, we separate diagnostics for AMR into 4 buckets. One is this big need, is it viral or bacterial? The next one is, what's the pathogen? The next one is, what antibiotic can I use? I need antimicrobial susceptibility testing. And then the next one is, how do I modify these antibiotics? When can I stop them? Should I start them? Et cetera, et cetera. And you'll see just a smattering of companies that are involved in each of these, okay? And these are important questions, a lot of activity. Okay, so next slide. So the question then begs, why are there so many companies interested in decreasing antibiotic use to combat AMR? And again, I'm very biased because we believe there's a big market out there. Next slide. So essentially, if you look at the O'Neill review, I think as impressive as it was, is a horrible underestimate of the true danger of AMR in the world. I know everybody quotes him, and we've had meetings at bioMérieux with Lord Jim O'Neill. And because of the methodology of this paper and this monograph, which is fantastic, by the way, and it's the first time people paid really global attention to AMR because it gave a cost for the first time in lives and dollars, or euros, whatever you want. It is a gross underestimate because the only AMR that they looked into is the one that they had economic data on, because he's an economist. So if you go to the next slide, and they only took into account GDP. So you've all seen this. So 10 million deaths by AMR in 2050, and you already heard at the beginning. But if you go to the next slide, I will show you that this is a gross underestimate because in the O'Neill report on the left, they only included the pathogens, the antibiotic resistant pathogens that they had economic data for. They did not include the ones where they had no economic data, which is a lot. So they included all of the economic and GDP implications of Staph aureus, Kleb, E. coli, HIV, TB, and malaria, which is a great list, but it's a very short list. They did not include in the O'Neill report everything else: strep pneumoniae, entero, C. diff, Acinetobacter, pseudo, the non-Kleb CREs in the world, H. pylori, salmonella, shigella, gonorrhea, and none of the fungi. So you can imagine that as bad as that number is, it is a gross underestimate of the impact of AMR in the world. And this is the kind of data that drives companies to say, I think that there's a market out there for diagnostics. Next slide. So I'm just going to quickly go through this. This is, again, the next 2 slides are underestimates. This is a great article in the US showing that this great statistic in the US that there's 23,000 deaths per year from MDRO is also a gross underestimate. And when they actually did look at, because when you die in a hospital in the United States and you die of a drug-resistant Klebsiella or an MDR Acinetobacter, and you die of sepsis, the cause of death is called sepsis. It's not called MDR Acinetobacter sepsis. So nobody really knows how many people die of MDR organisms. So if you actually do realistic modeling, it's not 23,000 per year in the US. It's 150 to 160,000 per year in the US. And this is from, I believe, 2018. Next slide. And again, the underestimates, if you look at a RAND report and a KPMG report on the economic implications, it is much bigger than what Jim O'Neill said in the great UK report. And I'm not saying that his report is terrible. His report is fantastic. But again, it's an underestimate. So the implications are going to be much greater for us in the next 10, 20, 30, 40 years. Next slide. And you've already seen this, but he is a big believer in diagnostics. Why? Because when you speak to him, he's an economist, and he says, listen, guys, anything that decreases demand is much more efficient than trying to improve supply. And if you're talking about antibiotics, new antibiotics is a supply, but reducing the demand for antibiotics is a demand-reducing strategy. And anything in economics that reduces demand is much more efficient and effective. So diagnostics reduce demand. What does that mean? Next slide. What that means is that if you take 2 scenarios, one on the left where you don't use diagnostics and one on the right where you do use diagnostics, and the funnel is the healthcare provider, the same patients coming forward with the same symptoms, if you don't use diagnostics, there's going to be a lot more antibiotics used. But if you use a demand reduction diagnostic, then you will have fewer antibiotics used in the end and less AMR. It's just a matter of economics, essentially. Next slide. So no talk is complete in 2021 unless we talk about COVID. You've already heard about COVID, but in the diagnostics industry, we have been massively impacted by COVID, not just in terms of the diagnostics to develop, but the whole mindset and attitude around diagnostics. Next slide. So what has the effect of COVID been on diagnostics? Next slide. The key changes are people now understand diagnostics. 2 years ago, if you asked people what PCR was, they would have no idea. Now everybody knows the difference between an antigen test and a PCR test for COVID. Okay, and that's a general increase in knowledge about diagnostics. The reliability on diagnostics, what would we have done for all of 2020 without diagnostics for COVID? We would have been absolutely blind and lost. So the importance and reliability of diagnostics has become very, very prominent worldwide. The location for diagnostics, nobody dreamed of doing diagnostics in 2019 in a parking lot. Nobody dreamed of having patients doing it at home. Okay, yeah, we thought about it, we talked about it, but nobody had really good broad diagnostics, and certainly not, PCR or antigen kits, sophisticated kits at home for home use. And we have that now. Who will perform the test? So everybody's used to a doctor performing it, a nurse performing it, the lab performing it. But now we have people in parking lots. We have people in pharmacies. We have people at home. We have the patients themselves. We have caregivers doing it. Okay. Time to results. It is no longer acceptable to wait 3 days for your lab to get back to you with results. Why we ever tolerated this in the past is beyond us. But now we see that we can get a result in 10 minutes, 15 minutes. I traveled to Canada 2 days ago. I went in for a COVID test at 11:25 in the morning. I had a PCR test done, a batch PCR test done, and I got my result by email at 3 p.m., 4 hours later. That's the way it's supposed to be. Okay, not this, yeah, we'll get back to you, and you don't get the email, you don't get the message, your doctor doesn't call you, it takes a week, and you're wondering where the result is, which is the way it was prior to 2020, by the way. Molecularization of infectious diseases and the reliance on PCR and the understanding that PCR can be so useful. The increased installed base of diagnostic platforms. It is amazing. We as a company have seen the massive exponential increase in the installation of diagnostic platforms, PCR, antigen, other, et cetera. And still to come, we hope that there will be improvements in the pre-test and post-test aspects. Who can order tests? Not just your doctor, not just your nurse, but other people who feel it's important. And post-test aspects like how to communicate results to you, okay? We are so bad. We were so bad in 2019. Labs were so bad. I'm sorry, but so lazy and so inefficient in transmitting results to patients in terms of their testing. You would wait days, if not weeks, for results of a test that only took an hour. The biggest question we get at bioMérieux is, we know that your tests takes 2 hours, or our BioFire test takes 45 minutes. Why don't I get the result until the next day or 2 days later? Well, you better ask your lab that, because the systems in place are horribly inefficient. But with COVID, all that is changing. Next slide. Other changes in COVID is AMR. So you've already heard a lot. I'm going to show you some stats, which means that it's even more important for us to have diagnostics. Next slide. So this is 2 surveys showing that the hospitals are filled with COVID patients. 75%, 3/4 of patients are getting antibiotics, mostly broad spectrum antibiotics, because nobody trusts their results. Nobody trusts when the COVID comes back positive that it's not a bacterial superinfection, blah, blah, blah. And patients are getting hit with tremendous amounts of antibiotics. It is the #1 drug class being used in COVID patients today. This is a group that is highly likely to develop more antibiotic resistance. And although we don't know what's going on with AMR right now because everybody's so busy with COVID, we suspect that when COVID starts to quiet down and we start measuring again, it's going to be horrific. But that's one of the problems. We're not measuring right now because we're too busy. Next slide. So obviously, we have seen secondary infections in COVID patients. This is just pneumonia. This is about 4 studies here showing that pneumonia occurs, and mostly a lot of drug-resistant pneumonia occurs in COVID patients about 15% of the time. Next slide. And This is just a smattering, a sampling of all of the MDR gram-negative outbreaks that have occurred in COVID-19 units around the world. So we are seeing this and we are getting reports, and we know that this is going to be happening as we start counting it post-COVID. Next slide. So other COVID consequences on AMR, like I said, very few people are doing AMR surveillance right now. They're way too busy in the hospitals. Can you imagine doing AMR surveillance in an Indian hospital today? They are way too busy trying to get oxygen and ICU beds and caring for people and keep them from dying in front of the hospital or in the bed. So nobody's got time for AMR surveillance. Nobody's got time for antibiotic surveillance. Nobody's got time for their stewardship programs. We're hearing this from everywhere, okay? And labs are not doing routine cultures. So they're not even doing AST tests. And I know that we see our volumes of tests in the hospitals. When you go into a lab, they go, we've stopped all our AST tests. We've stopped doing routine urine cultures. We've stopped doing routine sputum cultures. We have no time. Everybody's focused on COVID and COVID-related testing. Next slide. So unfortunately, we don't know what's going on. WHO has obviously seen this as a huge potential disaster following COVID. Next slide. With more deaths related to AMR. Okay, so diagnostics in the battle against AMR. Next slide. So this is how the industry comes in and how we look at it. So generally, we separate diagnostics into 6 different categories. Is it, sorry, can you go back? Can you go forward to the next slide? There you go. No, forward. So there's 6 categories. There you go. 6 categories of diagnostics for AMR to help us in terms of decreasing antibiotic use. Is it bacterial or viral? The big question that everybody wants to know. Which is the pathogen that's infecting this patient? What is the resistance profile? In other words, which antibiotics must I not use? What's the susceptibility profile? Which antibiotics can I use? Now, I know this sounds like it's the same, but it's not. Because when you do a genotype, you're looking at resistance. You cannot guarantee that anything's going to be susceptible. However, when you look at a phenotype, you can both do susceptibility and resistance. So there's a nuance in these 2 definitions. Obviously, diagnostics are used for epidemiology and surveillance, and they're also used now more and more for host response. Because although you get a pathogen in somebody, are they colonized or infected? Are they susceptible or immune? Is the infection under control? Just getting a pathogen from somebody, identifying it, is not enough. You have to know what's going on the host side, and that's a big push right now. Next slide. So these are the 6 categories. What are clinicians and what are patients and what are hospitals asking for? They're asking for faster results and more actionable information. And this is us as industry we have to focus on. Next slide. So faster, more actionable. How to create a diagnostic test to battle AMR. This is what everybody wants to know. I've got a great idea. Next slide. So what happens is somebody usually calls us or contacts us and says, Eureka, I have a fantastic idea. I know how to make the next greatest AMR diagnostic. Next slide. And they go, fantastic. I'm willing to sign a contract with bioMérieux, and I'm willing to move on and develop this diagnostic for world domination. Slide. They expect that money will fall from heaven. They will have a contract, and patients will be happy and thankful, and the world continues to turn in a positive way. Next slide. Unfortunately, life is not that simple. That just doesn't happen. Next slide. It is increasingly difficult to bring discoveries to the bedside. It's not just us who says this. This is a great editorial in the New England Journal. Why is it so difficult to go from a discovery to the bedside? The cost of research is increasing. The complexity of the research, both basic and clinical. The clinical demands. You have a great diagnostic. Do you know what happens? The clinicians say, it's fantastic, but how is this going to change my management of the patient? How is this going to save the hospital money? If you can't show that, I'm not interested. There's a tremendous regulatory burden that is just getting worse and worse all the time. We've got FDA, we've got CE marking, we've got an MPA in China. We've now got ongoing different countries that each demand their own regulatory trials. Russia wants their own clinical trials, et cetera, et cetera. Companies do not want to take risks. They're either on the public stock exchange and their investors don't want to take risks, or companies don't want to take risks at all and they'd rather go somewhere else. okay? And there's an increased requirement for health economic justification. Like I said, great diagnostic test. I love it. It's fantastic. I know that it does what it's supposed to do. I don't care. Show me how it changes my patient management. Show me how it saves me money. If you can't do that, come back another day. Next slide.
We've got about 10 minutes left.
Great. So, next slide. So, how do you go from the B path, from bench to bedside to business to benefits? Next slide. Essentially, what we do, the biggest obstacle from going to the bedside is a misunderstanding between the researcher or the innovator and the market access factors that are necessary for a successful diagnostic test. Next slide. And essentially, I'm not going to go through each of them in a lot of detail, but this is the process that we do in creating a diagnostic test. And the important thing that you have to remember is this is very complex. This is long in order to create something that's valid on the marketplace. And if you click to the next, that's it. A Me Too assay. This is just estimates, okay? And this is greatly underestimated by researchers and innovators. A Me Too assay, that's just another test on an existing platform, will cost bioMérieux and any other company about $5 to $10 million and about 1 to 2 years. A novel assay on an existing platform is about $10 to $20 million and 2 to 4 years. And a brand new platform, all those platforms that you saw on Till's slide, okay, and my first slide there, a new platform is anywhere between $100 and $200 million and 4 to 6 years, if not more. So before any company is going to do this, you can be sure that we're going to de-risk it. Next slide. So these are the factors that we use. Unfortunately, I'm sorry, there's 2 slides on this of all the factors that we go through when somebody comes to us with a fantastic idea, the eureka moment. Your eureka moment is then followed by what's the medical impact? What's the strategic fit with our company? Does it actually cannibalize or compete with our products, or does it actually complement one of our products? Can I use it for something else as well? That would really increase the market. Do you already have studies? Have you, you'd be surprised how many people come to us after doing something in 5 rats, okay? Or 6 mice, or 8 hamsters. That's just not enough. Do you have freedom to operate to prevent somebody from copying it the day after we launch it? Next slide. What are the technical risks? Is it a new technology or is it just a me too? Okay. Do we have access to clinical samples? Okay. Somebody came to us recently. I have a great diagnostic test for Crimean Congo hemorrhagic fever. Fantastic. There's a big need in the world. Yes, there's an unmet medical need for CCHF. Good luck finding clinical samples for CCHF to show the FDA the sensitivity and specificity. I'm not saying we're saying no automatically, but that's a big, big caveat for that. Okay. Is there competition? Immediately when you hit the market, if there's competition, you're behind. What's the business evaluation in terms of the market size? What's the sales capacity? How much R&D has to be put into this? And market access. So the last one, which I have here, which is market access, is one of the most important things, if not the most important things. Next slide. Everybody talks about the valley of death between researchers and patients, between discovery and commercialization. And I'm sorry to tell you, next slide, but there isn't a valley of death. There are 2 valleys of death, okay? The first valley of death is between the idea and the commercialization, but the bigger valley of death is between the commercialization and the rollout. Next slide, click. And this market access valley of death is a killer. What does it imply? Next slide. The market access valley of death includes what is the performance of the test? What are all the regulatory issues in front of you? Who is going to do the test that I have to address? If I'm going to address patients at home, it's a totally different regulatory pathway than for doctors or nurses or lab technicians who are going to be doing it. Is this test included in guidelines, whether it's national or local guidelines? Is WHO going to support it or not? Okay. Is it being reimbursed? We say in diagnostics, no reimbursement, no use. Nobody's paying for it. I don't care how good the test is. Nobody's going to use it. Is it accepted by clinicians or do they not like it? Does it actually change the management of patients? Is it supported by governments, hospitals, NGOs, etc.? Have they given it the green light? Or are they cautious? That's going to affect a lot of the market access. And what is the price? The final price to patients, insurers, and payers. the more you can meet these market access components, the better you can negotiate the second valley of death. But the second valley of death has killed most products before they get to market. Next slide. Reimbursement, the number one issue. Unfortunately, people say to me, what's the biggest problem in diagnostics? Must be technical, eh? It's not technical, my friends. It's reimbursement. Next slide. So the problem with reimbursement in diagnostics, as you heard from Till and the others, is there is no way to assess the value of a diagnostic test. Everybody talks price, 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 price. But the real value of a diagnostic test is in its economic and health value. So a test that saves you antibiotics and reduces AMR in the world should be reimbursed better than a vitamin D assay. I'm sorry, vitamin D assays are very important, but they're not as important as decreasing AMR globally. And they should be remunerated and valued and assessed and reimbursed differently. Next slide. So the barriers are technological, the barriers are market access, but our biggest barrier, click next, please. The biggest barrier is that reimbursement is not correlated with medical value of a diagnostic test. And therefore, if there's no good reimbursement, then there's no good uptake. Next slide, please. So I'm going to give you two success stories very quickly so that you don't leave all depressed. The two success stories, click next, please, are the BioFire platform that we acquired in 2014. And the second one is procalcitonin, which over 200 companies make today. Click next. Okay, so let's quickly go through the success stories to show you that there is a light at the end of the tunnel. Next slide. So BioFire is a success story. Lots of syndromic panels with 20, 30, 35 pathogens and targets on each panel, 45 minutes, totally automated PCR, great success story, great technology. Next slide. That's the respiratory panel. This is the pneumonia panel with resistance genes and pathogens and 33 targets, 45 minutes, fantastic. Next. So you look at it and you go, this is a great product. There are now 8 panels, 4 more in development. We've got everything from Ebola up to gastroenteritis panels, et cetera. Great product, great product. You look at it. Next slide. What was the pathway? The pathway was from the eureka moment until the, let's say 2020, with $1 billion in revenue, okay, you're talking about a pathway that is 30 years. All right. Now, it didn't take 30 years to get it to market, but it took a good 14 years to get it to the marketplace. Okay. So it's a success story, but the realism is that it takes a while. You don't go from eureka to the marketplace overnight. Next slide. The next slide is PCT. PCT is one of the most important biomarkers for antibiotic stewardship and when to start and stop antibiotics. It has an approval by the FDA for antibiotic stewardship. How long did it take PCT to get into the marketplace? Next slide. So from the moment that PCT had the first study in 1993 showing its benefit until the real market uptake by PCT was 19 years. 19 years to get it into the marketplace where there was some success and people are starting to acknowledge it. And there is still arguments today. If you look at Twitter and LinkedIn, there's still arguments today in social media about whether it's useful or not. We believe it's tremendously useful if used properly. But again, it's controversial even today, which is another 20, so it's 28 years after the original publication. And now that it's successful, we as a company, we have 200 competitors for PCT in China alone. So that means that even when it gets to the marketplace, now we have to compete with 200 other companies. So next slide. Bottom line is the simplistic conclusion of how to improve your odds of success of getting to the marketplace. Start with an unmet medical need. Don't start with a technology first and then look for the medical need. Start with a medical need first, which is very, very important. Take into account all the commercial success that's required, all the criteria that I mentioned, the market access, valley of death, all those components. Partnerships are very important, whether it's financial partnerships, whether it's technological, scientific partnerships. Maximize your intellectual property to prevent copies and copycats. Don't aim for the perfect product. Aim for what we call the MVP or the minimal viable product out on to get the maximal impact and then work on the product afterwards. And financing, it always takes longer and more money than planned. I can't tell you how many times we see this. Next slide. Thank you very much.
Right. Thank you, Mark, for an absolute amazing and excellent presentation. That was really fascinating to hear the practical commercial hurdles and consideration when taking a product, not just the commercialization, but actually really into the marketplace and in use. Thank you very much. We've got 1 minute left before we go to the next session. So again, a reminder that these slides are going to be available online, and that there is a Q&A session at 2:45. So if there are any questions, then we can answer those in that session. We are also recording, so you can watch this and listen this back later on. Don't forget to tweet. Twitter handle is @AMR Mission UK. Okay. Thank you, Mark. Next, I welcome Joe Frost, who is Innovate UK's NCP, National Contact Point for Health, and also the Innovation Lead for Health at Innovate UK. Joe is University of Cambridge educated and has held a range of strategic and program roles at the University of Oxford, the Medical Research Council, and the UK Research Office in Brussels. So Joe, a very warm welcome, and over to you.
Okay, thank you. Hi everyone, and thanks for joining us today. So as Peter said, I'm Joe and I work for UK Research and Innovation, and my email address is on the slide if you want to get in touch. Next slide, please. So UK Research and Innovation invest over £7 billion per year. UKRI consists of 9 different parts, including Innovate UK, where I work, as well as the UK's Medical Research Council. Innovate UK drives productivity and economic growth by supporting businesses to develop new ideas. And at the bottom of the slide, there's a link to our funding opportunities webpage and funding alert sign up. Next slide, please. So today I'd actually like to talk to you about the European Research and Innovation Funding Programme, which is called Horizon Europe. And this funds projects not just in Europe, but also beyond as well. Next slide, please. So as Peter mentioned, I'm one of the national contact points for Horizon Europe. We are a free network of advisors to support applicants. Our network is based around the UK and around Europe in many other countries too. Our services vary, but typically include informing and awareness raising, assisting, advising and training, and signposting. So you can contact me or the other national contact points with any questions you have. And there's a link at the bottom of the slide to sign up to the newsletter at the bottom of the page. Hopefully someone will post that in the chat as well. And also you can connect with me on LinkedIn, where I post regular updates. Next slide, please. So the EU has been funding research and innovation programmes through its framework programme since 1984. The previous programme, called Horizon 2020, is just finished. And Horizon Europe is the EU's brand new research and innovation programme, which is just starting and will run until 2027. Overall, it has a budget of at least €95.5 billion. As you can see at the bottom of the slide, the UK has agreed to associate Horizon Europe, which means those based in the UK will be able to take part in projects, which is excellent news. Next slide, please. So the European Commission has published a very useful Q&A confirming the UK's participation in Horizon Europe. As you can see on the left, this includes that UK entities will have the same rights to participate as EU countries. The funding rates will be the same, and the UK can also lead projects. The associated countries concept is not new. The previous programme had 16 associated countries, including Israel, Switzerland, Norway and Turkey. The exact list of Horizon Europe associated countries is to be confirmed, but other countries from further away like Canada, Japan and Australia have expressed interest too. Next slide, please. So the eligibility for funding. Horizon Europe will fund any type of organisation, including companies and universities that are established in EU member states or associated countries. It will also fund organisations from many low and middle income countries around the world. The exact list is to be confirmed, but in the previous programme, the EU automatically funded 122 low and middle income countries around the world. International European research organisations are funded, and you can also get funding for organisations in other high income countries occasionally if it's specified in your call topic or if their participation is essential for the project. But generally, organisations from other countries are eligible to participate, and they would have to fund their own participation if the EU doesn't fund them in one of the categories at the top of the slide. So for most types of EU funding as well, you'll need to form a consortium including at least 3 countries. Next slide, please. So on this slide, you can see an overview of Horizon Europe, which is formed of 3 pillars. And I'll explain the opportunities in the various parts of the programme today, and we'll refer back to this diagram so that you can navigate around. There's also some useful links on longer presentations and slide sets at the top right of the slide. Next slide, please. So I'm now going to talk you through some examples of Horizon Europe funding that you can get for AMR research and innovation. All the information on the slides is based on draft documents, so is subject to change, and we expect the final versions of the documents to be available within the next month. Next slide. So I'm going to start by showing you some of the opportunities in the middle pillar, which is circled in red. This part of Horizon Europe is split into 6 thematic areas known as clusters. And for each cluster, every 2 years, the European Commission publishes a work programme which contains a long list of the different core topics. For each core topic, there's typically 1 to 3 pages of information about exactly what the Commission expects you to do in your project. So I'm going to look at the first bullet point, the first cluster first, health. Next slide, please. In Cluster 1 Health, there's about 50 core topics in 2021 and 2022, and there's various ones relating to AMR, including Vaccines 2.0, developing the next generation of vaccines, and development, procurement, and responsible management of new antimicrobials. I've included on the slide a link to the draft work programme and the page numbers for these topics, so you can read them to find out more details. And the EU also has another type of funding called partnerships. This is where the EU gets together with other funders, for example, national funders, to run joint calls. And as you can see in the yellow boxes, there are 3 steps to setting up a partnership. First of all, there's some preparatory work. Then secondly, the partnership of research and innovation funders is established. And finally, as you can see in red, the partnership then holds call for proposals. Each partnership and call involves different countries, and sometimes countries outside the EU as well. So you'll need to check the partnership call text to see if you're eligible for funding. And as you can see at the bottom of the slide, there will be a partnership on One Health and AMR starting in 2024. And this will follow on from the current joint programme initiative on AMR, which I'll talk about later and Till also mentioned earlier. There will also be a new partnership on pandemic preparedness. We don't yet know when this will start or what countries will be involved. Also, I haven't put on the slide, but I will do by the time they get to the internet. There's also the Innovative Medicines Initiative and the European and Developing Countries Clinical Trials Programme, which are also EU partnerships. Next slide, please. So going through the other clusters quickly, Cluster 2 is about culture, creativity and inclusive society. Topics here include politics and governance in a post-pandemic world, global governance for a world in transition, the role of perceptions in shaping European societies and politics in the 21st century. Cluster 4 is civil society and security, which includes topics on improved understanding of risk exposure and public awareness in areas exposed to multi-hazards, enhanced assessment of disaster risks, adaptive capabilities and scenario building based on available historical data and projections, developing a prioritisation mechanism for research programming in standardisation related to natural hazards and CBNRE sectors, which are chemical, biological, radiological, nuclear and explosive threats. And the final topic in security is improved quality assurance and quality control of data used in decision-making related to management of natural hazards, accidents and CBRN events. Next slide, please. So moving on to Cluster 6, this is food, bioeconomy, natural resources, agriculture and environment. Topics include reaching the farm to fork target, research and innovation scenarios for boosting organic farming and organic aquaculture in Europe, animal welfare, vaccines and diagnostics for priority animal diseases, enhancing biosecurity and terrestrial livestock production, ecology of infectious animal diseases, biosecurity, hygiene, disease prevention, and animal welfare in aquaculture. There's also some international cooperation topics, which include a One Health approach for food, nutrition, security, and sustainable agriculture. And proposals in this topic must include African organisations. And there's a topic on agroecological approaches in African agriculture systems. Again, proposals must include African organisations. And finally, there's a topic on support for international research on infectious animal diseases. Next slide, please. So just in case anyone missed Till's presentation earlier, and it's worth watching that back for some more details on this. There's also a separate funding programme called the Joint Programming Initiative on AMR. It's global, as you can see on the map, and it's an international collaboration that aligns national research agendas and coordinates AMR research funding on a global scale, including from a One Health perspective. The JPI-AMR holds regular calls for proposals, which have their own funding rules. So when future calls come out, you'll need to check which countries and types of organisation are funded. And as Till mentioned earlier, you can sometimes get funding for countries not on the map as well. So for more info on this, see the links in the grey box, including how to sign up for the newsletter. And the next call for proposals will be about AMR therapeutics. At the bottom of a slide is a link to a summary of a recent workshop in this area, which will help scope the call. Next slide, please. So the JPI-AMR has a strategic research and innovation agenda. This focuses on the areas on the right of the slide, including therapeutics, diagnostics, surveillance, transmission, environment, and interventions. And you can find out more on the JPI-AMR website. Next slide, please. So Horizon Europe also has some bottom-up funding opportunities. So these are opportunities that are open to all areas of research and innovation, including AMR. So I'm now going to take you briefly through each of the programmes shown in red on the slide, starting at the top left with the European Research Council. The European Research Council, next slide please. The European Research Council gives long-term funding for groundbreaking research. It funds a principal investigator known as a PI and their team, and the PI can choose to do research in any field. Projects are selected for funding based on the excellence of the PI and the excellence of the research project, and the ERC has 4 main grant schemes. Starting grants are normally for PIs between 2 to 7 years after their PhD. Consolidator grants are normally for PIs 7 to 12 years after their PhD, and advanced grants are for active researchers with a track record of significant achievements in the last 10 years. And then the synergy grants, which fund 2 to 4 principal investigators to do an ambitious joint project that they couldn't do alone. Next slide, please. This slide is about the Marie Sklodowska-Curie funding. As you can see in the top right, this funds all areas of research and innovation. And any types of organisation can get funding, including industry and academia. In general, it supports research and innovation projects that also have an aspect of career development, training, and/or networking. The first funding scheme is doctoral networks, which provide full funding for an international consortium to train a group of PhD students, aiming to give them experience in different sectors, for example, to spend some time in both industry and academia. The second is the Staff Exchange Scheme, which funds an international consortium and allows different staff working in the consortium to go on short secondments for up to 12 months per person. The third scheme is postdoctoral fellowships, where you can get funding for someone to do a 2 to 3 year fellowship, and they can spend some of their time in industry as well. The final scheme is co-fund, which is where the European Commission provides extra funding for existing fellowship programmes. Next slide, please. So this slide summarises the European Innovation Council. As you can see on the left of the slide, EIC funding covers everything right from the first idea through to the market. As shown on the diagram, there's 3 main parts of the EIC: the Pathfinder, Transition, and the Accelerator. For each of these, there's an open call where you can apply with any topic, and these calls are listed in the middle of the slide. And there's also challenge calls where the Commission specifies the topics. These are listed on the right-hand slide for 2021, but you need to check them for future years. If you'd like any more info, the contact points are in the grey box. The light blue box includes a link to the European Commission's Info Day about the European Innovation Council, a link to the EIC website, and also a link to the work programme which lists the call topics. And in the orange box at the bottom, you can see that UK organisations can access the majority of the EIC, apart from the EIC fund part of the EIC Accelerator. And there's more details in the Q&A on the slide. Next slide, please. This slide is about the Eurostars programme. Eurostars is a joint programme between Eureka and the European Commission, and it's co-funded from the national budgets of participating Eureka member countries. It funds transnational market-orientated collaborative research and innovation projects. The projects must be initiated and driven by research and development performing SMEs. They're normally biannual calls, which are open in scope, and we think the next call will probably open in July and close in October. There's 45 Eureka member countries, including the UK, which are shown on the map on the right of the slide. 36 of these countries take part in the Eurostars programme, including non-European countries such as Canada, South Korea, and South Africa. The projects can be both bi or multilateral, and the rules about which countries and which types of organisations are funded are explained in the call documents. There's also 2 other Eureka funding schemes, Global Stars, which funds projects including Eureka and non-Eureka countries, and each call specifies the countries involved, and there's network projects and cluster projects. I'll include some extra slides on those on the slide pack. Next slide, please. Final scheme I'd like to talk about is COST. The COST open call has regular deadlines, with the next deadline in October. You can apply for any research and innovation area, including AMR. COST funds the setting up of interdisciplinary research and innovation projects in Europe and beyond. For example, funding organising meetings, training, missions and networking. So COST funds the global networking of people who are already doing research and innovation. You can also join existing COST networks. For example, there's a European network on the optimisation of veterinary antimicrobial treatments. Next slide, please. So that's the end of my presentation. I know there's a lot of different opportunities to take in, but hopefully this overview was useful for how EU funding can help you collaborate around the world. And if you missed Till Bachmann's presentation earlier, you can also watch that back to find out about the Nesta Longitude Prize. Thank you.
Thank you, Jo, for such a comprehensive overview of all the funding and other opportunities that are available for AMR specialists. Just a reminder to everybody, if you do have questions, we have a dedicated 2:45 to 3 o'clock session for questions. So please post those in the chat box on the platform and we can take those questions in that slot. Okay, so next I welcome Mimi Hoti, who is Business Development Manager at the UK National Institute for Health Research, Office for Clinical Research Infrastructure. Mimi has a PhD in molecular genetics from the University Queen Mary in London and held management roles at UCL and Bath and the London School of Medicine and Dentistry. Mimi, very warm welcome and over to you.
Thank you very much, Peter. Hi, everyone. I hope you can hear me okay. My name is Mimosa Hoti, and I am a Business Development Manager at NOCRI. And today my talk will give you an overview on what the NIHR is and how we can support companies translate the AMR innovation into the clinic and onto access in the UK market. Next slide, please. Next slide. Thank you. Thank you very much. So what is the NIHR? The NIHR is a virtual organization whose work is hosted by NHS trusts, universities, and life science organizations. So we are centered on England, but we work very closely with the devolved nations as well. Our scope is quite broad, so it covers from early translation of research, clinical trials, and applied health and care research. And it is the most integrated healthcare system in the world. Now, the aim of NIHR is to improve the health and the wealth of the nation through research. Now, the NIHR is a funder, and we are the largest funder of health and care research in the UK, and we manage over 1.2 billion per year on behalf of the Department of Health and Social Care. Now, this money funds much of the country's researchers, facilities, and processes across the NHS, social care, and universities in order to be able to deliver the clinical research. Now, a large portion of this funding, as you can see from the pie chart on the right, goes towards the infrastructure. And what we mean here is primarily buying the time of clinicians, academics, and the research nurses to deliver the research. A quarter of that budget goes towards the research programs, which are competitive grants to help finance specific parts of research. Also, 100 million goes towards the NIHR Academy, which is responsible for the development and coordination of NIHR academic training, career development, as well as capacity development. Next slide, please. The UK is one of the most attractive places in Europe for regional headquarters, R&D, and manufacturing, and offers the lowest operating costs. Now, on this slide, I just wanted to show an overview of the top 6 countries based on the number of commercial trials. So this is industry-sponsored across the clinical phase setup. And as you can see, UK is one of the top. Now, within the UK, 100% of the NHS trusts are actually research active. So this includes both academic and commercial studies. And around 500 AMR studies were delivered over the last 5 years across the innovation pathway, with over 80,000 patients recruited. Next slide, please. Our offer to industry. Next slide, please. So we support and deliver life science industry research across the innovation pathway. So from early translational through to applied health research. So giving patients and the public faster access to new diagnostic therapies and medical devices. So we do work with a diverse range of industry sectors. So this includes diagnostic, medical technology, and biopharmaceuticals, as well as associated industries such as digital and artificial intelligence. So on the slide shows where in the innovation pathway the NIHR can offer support. So this is for medtech, IVD, and therapeutics. Next slide, please. So our offer to industry. NIHR can support life science companies generate the required clinical and economic evidence to progress the development of the new therapeutics, medtech, diagnostic, and digital products towards the market. Now, we work with companies at any stage of their clinical development pipeline by helping them access expertise. So we have a unique view on the strengths, capabilities, and interests of over 25,000 researchers across our country's leading universities and NHS trusts. So we can support you in connecting with expert clinicians, world-leading academics, health economics, and much more. And we can also connect you into our regulators, ethic bodies, and those positioned to help you gain market access. We can also help companies access facilities. So we can help you gain access to cutting-edge facilities and some of the most advanced clinical tools from across the country. We can also help in trial management, so trial setup and delivery, from experimental medicine and translational research through to large-scale multi-site studies and investigations. We can help you set up and deliver your research across the whole of the UK. We can also support access to patients and samples. So we can help you to gain access to very large and diverse cohorts of patients spanning a wide array of disease. In addition to patients, we can help you gain access to clinical and biobank samples as well. And we can also support you in identify and access patient groups for involvement in your research and product development. So whether that is to help you gain insight into the patient's perspective on your innovation and their disease, or to obtain input into your research design. We can also help to access the data. So through the NIHR or one of our UK partners, we can support you in accessing a very broad and deep array of clinical and research data for use within your research. So whether that is primary or secondary care data, health coding data, or data generated through research. We can also help access research funding. So the NIHR has a variety of funding schemes that can support you in the development of your innovation. This includes accessing funding programs dedicated to medtech and IVD, AI, and therapeutic development, supporting innovations at proof of concept right through to real-world evidence generation and applied research as well. Next slide, please. Next slide, please. So we can help you navigate the UK's research and health system by connecting you to those different centres and networks as shown in the slide. However, due to the time constraint, I will only briefly mention a few of those centres in my presentation. Next slide, please. So there are over 25 AMR centres of excellence across the UK, which are funded by NIHR and our partners, and these can be seen in the map on the right. So this includes top universities such as Oxford, Cambridge, Imperial, UCL. Next slide, please. So we have biomedical research centres, or short BRCs. There are 20 BRCs across England, as you can see in the map, and they are a partnership between NHS Trust Organisation and universities. So the BRCs undertake high quality early translational and experimental research. So the aim is to translate scientific breakthroughs with potential to develop into new treatment, diagnostics and medical technology for the benefit of the patient, the public and the health and care system. Now, a few of these BRCs are more specialized. For example, the Royal Marsden, which only do cancer research, Mooresfield, only ophthalmology, whereas majority of the BRCs host research themes across a range of disease and therapeutic areas, and few of these have AMR or AMR-related themes. Now, our experts are keen to work with companies to better understand the mechanism of disease, evaluate new health technologies and therapies, discover new drug targets and biomarkers, and also repurpose assets for new indications. One of our NIHR colleagues, Professor Julian Marchesi from Imperial BRC, will be presenting tomorrow. Next slide, please. We also have medtech and in vitro diagnostic cooperatives, or MICs for short. There are 11 MICs across England, and there are leading NHS organizations which act as center of expertise that bring together patients, clinicians, researchers, commissioners, and industry. So the MICs aim to build expertise and capacity in the NHS to develop and evaluate new medical technologies in vitro diagnostic tests. Now, each MIC has a different focus and is hosted by a different NHS trust and can support companies from ideation and prototyping through to evidence generation and adoption. And we have a talk from Dr. Philip Turner from Oxford NIHR Community Healthcare MIC on Wednesday that can give you more detailed information. Next slide, please. We also have the Clinical Research Network, or CRN. So the CRN is comprised of 15 local CRNs and 30 specialties who coordinate and support the delivery of high quality research, both by geography and therapy area. The local networks help to increase the opportunity for participants to take part in clinical research and ensure that studies are carried out efficiently. The CRN is also uniquely placed to support companies deliver research at a scale across the entire health system. Next slide, please. So with regards to funding, the NIHR has over 10 different funding programs, each one dedicated to the type of innovation or stage of research being conducted. So here I will briefly mention a few of them now. So we have the Invention for Innovation, or I4I, which funds early stage prototype development and clinical evidence gathering. We also have the Health Technology Assessment Program, or HTA, which supports research that is immediately useful to patients, clinical practice, and policy or decision makers. So the HTA research is undertaken where some evidence already exists to show that the technology can be effective, and then this needs to be compared to the current standard intervention to see which works best. And technologies in this context means any method used to promote health, prevent, or treat disease. We also have the Efficacy and Mechanism Evaluation, or EME, and this is a partnership between NIHR and MRC, and this primarily supports clinical trials and other robustly designed studies that test the efficacy of interventions. Next slide, please. Next, please. Thank you. As mentioned before, we can also provide you with access to a wider UK system, helping you connect into regulators such as NICE and MHRA. NICE provides opportunities for industry to engage with them at all stages of health technology development, so helping companies to deliver better and measurable outcomes. So we highly recommend companies to engage with them early. With regards to adoption and dissemination of innovations, even though NIHR does not support this directly, we can connect you with those positioned to help you gain market access, so including helping you identify clinical champions for your innovation. Now, the dissemination and adoption of research into clinical practice in healthcare settings is a complex and challenging process. So having these clinical champions to facilitate the implementation and the adoption of evidence-based practice and to overcome these organizational barriers is crucial. There are regional alliances and partnerships in place to offer you support, advice, and access to collaborators. And one of them is the Academic Health Science Networks, or AHSNs. There are 50 networks across England, and the purpose is to improve the patient outcome and generate economic benefit by promoting and encouraging the adoption of innovation in healthcare. We also have the Accelerated Access Collaborative, which is an umbrella body across the UK research ecosystem, whose mission is to provide more joined-up support to innovators and also to help identify high potential products and to accelerate the access to these products. Next slide, please. Next, please. Thank you. And just to summarize now, so our offer to you is that we can support you in gaining access to world-leading expertise, research management, and provision to enable you to generate the evidence required for market access. We can support you to build a bespoke collaborations around your research interest. We can support you in access to funding, and we can connect you to the wider UK infrastructure and government. Next slide, please. And thank you very much for listening. If you have any specific questions or you would like to find out more about NIHR, then please feel free to email us at nocre@nIHR.ac.uk, and we will be more than happy to help. Thank you very much.
Thank you very much, Mimi, for that excellent presentation and taking us through that essential support and funding landscape. So that brings us to the conclusion of all the formal presentations. So I am now going to revert to the Zoom call we are on, and we're moving into the Q&A session. So again, encouraging you to post any questions you have in the chat on the BetaMatch platform. Before I do that, obviously, again, just want to thank all the speakers for that excellent contribution. It really has been fantastic quality. Thank you so much for that. And also thank you for all the delegates who have been listening and watching. Again, much appreciated. And I do hope that you've had a really fantastic afternoon so far. Hello.
I can hear it.
Okay. Craig, I'm just going to share this screen again, and then if you can bring it up on the live stream, that would be good. Welcome to the Q&A. Is this live now? So should we all be on camera? But it's not a big problem. So, Craig, are there any questions from any of the delegates so far? So, any of the speakers, is there anything that you want to add, or anything that's been forgotten, anything you want to share? If there are any questions, then we can wrap it up. It's not a problem, but this is obviously a good opportunity to cover any points that haven't been covered so far.
Well, maybe I could add one thing, is that following up on these excellent presentations, I would like to mention that it is still possible for delegates to schedule to invite people for one-to-one partnering sessions. I also invite people who have been invited to respond to the invitations.
Yeah, that's a really good point. Thanks, Martin. The whole point, part of the whole point of this mission is to connect you all up. So we've put that functionality or those platforms and all the effort in to be able to do that. So do sign up to Beat to Match. We want
as Luke already said in the beginning of this afternoon, we have over 350 delegates, and so far about 160 public sessions have been scheduled. So this is an excellent opportunity to get in touch with companies, academia in something like 60 countries.
Absolutely. Thanks, Martin. A very good point. So unless there are any other questions or any other points, I am going to once again.
I could add something on the EU side. So for the health work programme and the different work programmes in the clusters in Horizon Europe, we think the Commission is going to have some information days, probably early next month. And also there's likely to be some partnering events next month for those EU calls as well. So if you sign up to my newsletter, we will let you know when those events are opened. Hopefully you can go along with some people you've met here today as well to see if there's any funding opportunities for you there.
Thank you, Joe. Yes, that's an excellent point. So in terms of next steps, this obviously concludes today's session. We will be back tomorrow at the same time, 1 o'clock UK time, where we have, again, a range of excellent speakers to cover antimicrobials and antimicrobial treatments. And then on Wednesday, the same time, where the theme of the day is prevention and stewardship. So again, the same principles apply as today. Sign up to any sessions you want to watch. Sign up to the platform, and hopefully you can connect with others and really shape up some excellent partnerships. So thanks again to all the speakers, to Ruth, to Till, Mark, Joe, and Mimi. Very much appreciated that you've taken some time out to come to this event. And thank you so much to everybody online who was listening in and was watching. I hope you've had a fantastic afternoon. I certainly learned a lot. Again, thanks to everybody, and we will see you shortly. Bye.